Okay, so Assalamu alaikum warahmatullahi wabarakatuh. Welcome everyone on board. We started reviewing the whole of anesthesia, and yesterday we started pediatric anesthesia. So we will continue from where we stopped yesterday. So basic uh, like mode that whenever you have a pediatric patient for anesthesia care, so basic thing which you will be doing is that there are certain physiological, pharmacological, and anatomical consideration which will be there in any pediatric patient. So your aim will be to handle that situation in that way, that your approach will be in a way that you will be understanding that change, and you will be anticipating the problems. Okay, and your management will be according to that thing. So there is a problem related to anxiolysis, IV line, cardiovascular system, respiratory system, altered pharmacology. So we discuss about that, and we discuss few of the diseases. So today we will be starting from tracheoesophageal fistula because we had covered some of the diseases. So can someone tell me what is tracheoesophageal fistula?
Sir, it's
Yes,
a congenital disease in which
I will stop it here.
there is a
There is a trick. There is a trick in this question. Can tracheoesophageal fistula only congenital anomaly?
no, sir,
Can it occur
could be
in
due to surgery. Yes,
iatrogenic? Can it occur?
yes,
Okay, so just for a food for thought, that this diaphragm, this tracheoesophageal fistula can be in adults. Okay, because of any trauma or any pathology, any corrosive injuries. There are so many reasons in which there may be creation of tracheoesophageal fistula. Okay, so this is just food for thought. Okay, so now continue. So what is congenital tracheoesophageal fistula?
in congenital tracheoesophageal fistula, there is a connection between esophagus and trachea, which
Okay,
may lead to difficulty in ventilation and increased risk of aspiration. It's a
okay.
surgical emergency and
Is
should
it a
be,
surgical emergency?
yes, it is a surgical.
No. Are you sure?
Sir, I recently read that it should be done within 24 hours.
Does it mean that it is a surgical emergency?
Think so, sir.
No. This is again because, just tell me one thing. If the patient has, because of aspiration, the patient has developed pneumonia, would you like to do the surgery in that time? Number one. Number two, the patient is not able to take anything, the baby. Okay. So would you like to do a surgery in a patient who is dehydrated or things like that? So again, the same things will occur because the patient will not be able to. How? What is the usual picture? That they are trying to, there is vomiting, and then they are trying to, baby is not able to take it out, and when they try to pass ng is not passing. Okay, this is
Yes.
one of the picture which is there if there is tracheal atresia. Okay, so I don't think so this is surgical emergency. Just consider. If you have a doubt, don't say. Okay, say that it is a condition in which there is this problem. If you are not sure 100%, don't don't commit the word that this is a surgical emergency. Okay.
Okay, sir.
Okay, so there are various types about it. So this vectoral we all know. I will not waste time in it. All of you know about it. So um, what else? What will be the challenges in other than the normal pediatric anesthesia challenge? So baby can be premature. So concerns related to prematurity will be there. Okay, there may be associated congenital anomalies, as here this vertebral anomaly and imperforate anus and cardiac defects and tracheoesophageal fistula, renal agenesis. These they can be there, not always in as a syndrome, but sometimes isolated. One thing can occur, two thing can occur like that. Okay, so then they can. The next question can be about the types. So
Yes.
so I think this type is the most common one, the C one. Am I right?
Yes, sir.
Type C is the most common one. Yeah, this one. Okay. Uh, so try to remember one thing. Type C, maybe you can forget. And another thing is that the more important thing that what it is. So it is isolated esophageal atresia with distal trichoesophageal fistula. Okay. And this is a classic picture because there is no communication between the upper part of the proximal part of esophagus with the distal part. So NG tube, they are not able to pass. Okay. So, so you should be thinking about converting in the names rather than A, B, C, D, E, F, G. Okay. So I hope that you people are only familiar with this thing, but I think you should be knowing this is both atresia. Okay. Isolated, this is atresia. This is so you proximal communication, distal atresia, things like that. So you should be knowing how to explain individually the types. And diagnosis antenatally can be done, but not very easily. So this is one thing. The other thing, what else? There will be some gynecological things which may be uh, present. So polyhydramnios is one of them. And then what else? Okay, so like this question is asked in that way, that how will you evaluate? So should be your approach? Who want to answer this question? What should be your approach in evaluating this patient? Vajiha, would you like to tell? What investigations would you like to do? Yes, please.
Yes, sir. On the on the basis of history, examination, and investigations, I will evaluate this patient.
Mhm,
On history, I will inquire about any other congenital abnormalities and
mhm.
for sign and symptoms related to that. His
Okay. Actually,
like his
Vajiha, just try to,
gallstones or
you are telling the right way, but actually, the question which I asked, what investigations would you like to do? So, in exam, try to understand what examiner is asking you. You're right. But because you don't need to tell again and again that in history, I will ask this. There will be history of these things. In examination, we can find these things. In investigation, we can find these things. So it will save time. Okay. So what investigation, again, I repeat the question, what investigation would you like to do and what findings you can get?
well, I will do CBC,
What
and
can you find?
in CBC I will look HB and platelets, TLC count,
Okay.
or serum electrolytes. Patient may be in infectious state, or due to recurrent aspiration and vomiting, there may be electrolyte abnormalities.
Okay.
X-ray,
So that's more
echo,
important investigation than CBC here.
yes, sir.
Okay. So
And
that's more
echo for
important.
any cardiac,
Yes. Echo,
yes, sir.
echo, chest X-ray.
And
Okay. So
stress rate,
and
BSR,
individually for anything you see, renal ultrasound for renal problem, lumbar ultrasound for spine problem. Okay, so you just think about vectoral and just tell what you need to do. Cardiac defects, echo, imperforate NS, physical examination, and the rest of the things according to the renal agenesis ultrasound. Okay, limb abnormalities on clinical examination. So
yes,
you will be trying to do this, and then rest of the thing will be according to the type and according to the severity. Not every trichoesophageal fistula will have the same severity level. Okay, So
Yes.
now you will optimize the patient and then like
Is that like patient if patient is dehydrated and yes,
yes, so you will try to cover as much as possible,
or uh,
and then you will go ahead. So in addition to, you will say that in addition to standard 1 and standard 2 monitoring,
I can go for
uh,
ABGs depending on the severity of
yes,
the disease.
ABGs and pulse oximeter, both sides, so that you can monitor the ductal, preductal, and also ABGs from the preductal. Okay. And arterial line will be actually a challenging thing to do in pediatrics, especially if it is neonate. But anyways, they will write about it. And then surgical approach, you can have few words about it. Now, how to manage the airway of this patient?
So if the there is a thing written in the books that if the trough is above the carina, then the ETT placement would be of concern that first it should pass away from the top and then move slowly in endobronchial intubation should be done and then slowly removing the ETT just above the carina and below the point of fistula.
So how will you, like, you will be
That will
listening
be the correct.
bilateral, and the place where you listen to the gurgling sound, it means that you are in the gurgling sound in the epigastrium. At that place, you are like that place. That part is the one which is communicating
Fistula
with
with
the
the
fistula.
esophagus.
Like that is the fistulous part. So the thing which you were telling is that you have to cross the fistula. Okay. So the basic thing is that the tube should be between the carina and the fistula. Okay. It
Yes,
should bypass, because if you it is above that, the air will go to the stomach as well. So it can cause it can cause problems. So that is the basic purpose, that the tube should be passing. So that the way which you were telling, that you will push the tube endobronchial and gradually withdraw till you listen to the gurgling sound in the epigastrium, and then you will push it further. And it is very difficult to use the. I'm not sure. I don't have much experience of pediatric anesthesia, but maybe it's possible to do some this one bronchoscopy. I'm not sure about it. I think it's difficult. Pediatric bronchoscope is not of that accuracy in it, but uh, like again, they are not expecting they are not expecting the the very hi-fi things. The basic safety issue is the so ultrasound can be used, chest radiograph, and like auscultation of breath sound, right or left main stem intubation with gradual withdrawal until bilateral ventilation established, ideally about 1 centimeter above the crine, which I was telling you. Okay.
and sir, I
So yes,
major gastric decompression should be done beforehand.
yes,
And there was a thing I remember now that during RSI or elective ventilation, I would not manually ventilate to
yes. Let's try to
insufflate the
have
stomach to avoid
spontaneous.
insufflation.
Try to keep the spontaneous ventilation, because if you ventilate, it will air will go in. There will be aerophagia. There will be problem in ventilation even further. Okay. So
Yes.
that's if you need to ventilate, do with gentle low airway pressures. Okay. So that's how, because this is one question they will be asking. The rest of the things you can just make the same way. That if it is neonate, the concerns in the neonatal anesthesia, the same concerns will be here. Okay. So the same way, basically, and this there a lot of post-operative complications. So post-operative complication mainly are actually surgical, and because of like if it is repaired properly, then things can get better. So one will be an anastomotic leak. So they can ask you one question: would you like to extubate the patient, or would you like to keep the patient ventilated?
Sir, it will depend on the hemodynamics and respiration, proper respiration.
Like weaning
If
criteria, if it
patient,
is feeling, then it's better to extubate. Because if you will keep the patient mechanically ventilated, actually it's not good for the surgical outcome. So they try to extubate if possible. If not, of course, they will keep it, uh, continue. And then if it is esophageal atresia, it's a long a number of time. The structures may lie as they have written here, may require multiple balloon dilatation later on. Okay, because it is restructure, and actually with the growing age, the size is also increasing. So sometimes you need to have further. Uh, Another question they can ask you, that would you like to do this surgery first, or if there is associated cardiac anomalies, what would you do?
okay, so then this will become a multidisciplinary approach after discussion with the cardiologist and involving surgeon,
Yeah,
cardiologist
the
and surgeon.
neonatal intensivist, neonatal cardiologist. So it will depend on the severity of cardiac disease, and like it will be a multi. So I think they are not expecting more answer than this one. Usually it will depend on the situation. Okay. And as from where we started, Abdul Rahman said that it is a surgical emergency. I don't think so. It's a surgical emergency. Again, you have to optimize the things in other way, and then you will proceed. So I think that's
Yes,
maximum
sir,
I
I
can.
misunderstood that it should be done within 24 hours. I
Yes, it
thought it
doesn't
was.
mean. Yeah, because usually it's sort of medical, because if they will not operate, the things will get worse. So, but it is related to the medical condition, because it will cause more and more aspiration. It will cause more and more morbidity. So that's the purpose that it should be done within 24 hours. That's with that reason. But if you pass the endotracheal tube, you like separate the lung, you isolate the lung. Then, for example, if lungs are not mature, they can give some time for the lung maturation. They can give some time to correct the electrolyte before going for surgery. Okay. So I think that's a better answer, that you will optimize the condition. You can secure the airway. Securing the airway will be more important. And then rest of the things you will do accordingly. Okay. So these are few words about tracheoesophageal fistula. Mm. What is cerebral palsy? Yes. What is cerebral palsy? Who will tell? Can you hear me?
Yes, sir.
Usually, it is a neurological disorder because of any, like it can be a congenital one, but it can occur at the time of birth because of hypoxia or because of anything leading to uh, injury in the brain. So this is like one of, there are so many reasons which can lead to it. And isolated
It
cerebral
occurs
palsy can also occur.
due
Okay.
to
In which,
hypoxia during labor or delivery.
yes. So this is like reason, and then there will be different types, like whether it is spastic or it is hypotonic. Okay. So it can be the variety of picture you see. It may be hypertonic, dyskinetic, ataxic, or mixed. So there will be variety of, but overall, what will be the common challenges? These
Okay,
patient,
developmental.
yes, developmental delay, number one. Number two,
Patient may be a known case of epilepsy.
okay, so
On
epilepsy is
epilepsy.
second problem.
On
Anti-epileptic drugs and their problems.
yes, patient may have contractures and difficult in positioning
Very good.
and difficult IV line could be a possibility.
Yes, like our logistics issues, this will be difficult airway. Okay. And if it is associated with any neuromuscular problem, okay. So neuromuscular problem, so the use of neuromuscular blocking agents can be a problem. Like it can create some issues. Then there are repeated pneumonias, one because of gastroesophageal reflux disease, and also like chronic, a number of times they may be bedridden. So the things related to those things you should be considering. Okay. Nutritional problems can be there. Okay, so again, some urological problem, gastrointestinal problem. So these are the if they have rigidity, they may be taking anticonvulsants and also antispasmodics. So sorry, not use antispastics like baclofen. One of the medication which they use it baclofen. Okay, so baclofen is GABA receptor agonist. So it's the inhibitory neurotransmitter. So it decreases spasticity by inhibiting the release of excitatory neurotransmitter aspartate. So this is one thing because baclofen now it's available in Pakistan, I think. And, so if you want to conduct anesthesia, a number of time they are coming for MRI, number of time. Okay. So these are the questions you should be thinking. So they are coming for release of contractures of as orthopedics, uh, pain intervention for botulinum injection for again for spasticities, for because of poor hygiene and everything. So dental clearance or dental extraction. So if there is neurological problem, so VP shunt like that. Okay, manual evacuation like of stool, upper and lower G endoscopy, percutaneous gastrostomies because they have poor problem in eating because of a lot of so these are the things which they can be about the because now you can construct the answer. Your answer should be like constructed in a way that you should know that you have to conduct the anesthesia. So monitoring like a preoperative anxiolysis, airway management, monitoring, fluid management, analgesia. You just have to cover like we discussed yesterday. So same principles will be here. The main things like about so you should be knowing for each disease. If you know few things, believe me, your topic will be covered very easy because the basic things for any pediatric patient will be the same. So now you just have to think that cerebral palsy of neurological problem, fits, gastrointestinal reflux disease, pulmonary problems, bed concerns related to a bedridden patient. So these will be the extra things which will be thinking. Okay. And that's how you will cover this topic. Remember one thing, they don't need a PhD. Actually, this is very nice thing. I found it here. This is actually FRCA mind maps. So in mind maps, they have made for a lot of topics. I highly recommend you to have a look. Okay. So sorry, this is not easily visible here. Okay. Okay. So you see chronic lung disease due to prematurity, aspiration, abnormal loss makes aspiration commoner, things like that. It is just a summary which we have discussed. So there is a special folder actually where you can find these FRCA mind maps. I will show you. This show you will go here. You will find here. Okay. These are FRCA mind maps. Whatever were available on the website, I had downloaded and made files. You see? So you can review for a number of topics here. Okay. Okay. Hmm. Is there any change in? Actually, we will do the resuscitation in a separate setting. Okay, so I will just try to have few words about few of the surgeries. So inguinal hernia, what will be the concerns in pediatric inguinal hernia surgery? Yes, please. So if it is obstructed or not obstructed, okay. So if it is obstructed, so what will you be thinking? The Abdurrahman, would you like to answer?
No, they're obstructed if it's obstructed hernia, we could be thinking about uh, increased risk of aspiration, electrolyte imbalance, and
Dehydration,
dehydration
very good.
and
Pain
pain,
and the all the physiological
ischemia of
pharmacological.
ischemia of gut, and
Sorry.
gut ischemia. It could be.
Yes, so the
eh,
chances of sepsis, if it is
Yes.
ischemia, so even they need to do the resection anastomosis. So that will become uh, a major problem. So like any actually hernia, like even if it is an adult or pediatric, actually a number of concerns are the same. But what is the content of the sac, whether it is obstructed or encapsulated and gangrenous, okay? And but of course here the clinical symptoms will not be as evident as in adults, so it will be presented as an acute abdomen actually, and the rest of the things will be you see, the same things will come here. The dehydration, wherever, whatever you do, go, the same principles will be there. Any case. So I will not repeat it because we discussed in detail yesterday. Okay. And if it is sepsis, so you will go on the direction of sepsis. You will take the lactate level, you will send the culture, you will start empirical antibiotic, you will give fluids, and the rest of the things are almost the same which we do in any case of sepsis. Okay. Fluid management we discussed yesterday. Examination. I don't think so. There is any specific. If it is laparoscopic surgery, then you can give local infiltration or you can consider tab block. But again, we discussed yesterday that what are the basic principles of calculating uh, dose uh, of in pediatrics. I will just quickly repeat that you will calculate the safe dose first and then you will calculate the volume. So, if, for example, if you have a baby who is 10 kg, so you will calculate is as 20 milligram as 2 milligram per kg. So now 20 milligram is if you have 0.25%, it is 8 ml. So 8 ml you will dilute in whatever volume you require. Okay, so this is the basic principle, and same will be applied here. And okay, so this was actually yesterday when we were discussing, I was not sure that how much volume will be increased. So if you give 8 ml per kg, so it will raise the sorry, of course the whole blood concept is finished. So 4 ml per kg, if you give PRBCs, it will raise 1 gram per DL. Okay. So yesterday I told it, but I don't remember this that how much hemoglobin it will increase. So that is how this is an important point. Mm, these topics we actually discussed yesterday. Caudal block, hyolinguinal block, extubation. Okay. Okay, so if pediatric eye surgery, actually squint surgery, or there is another procedure which is examination under anesthesia. So actually it's a tricky procedure because it will be a quick procedure, and maybe uh, that like you still you need to maintain the airway, and because it's sort of the same place where surgeon will be there, so it sometimes become difficult to do it under mask. So it's better, always better to secure the airway. Okay. And uh, then that uh, a number of time, if it is any manipulation with reference to nasonephrimal duct, there may be bleeding. So actually you will be asking the surgeon, do they need, are they expecting bleeding? So if they are expecting bleeding, then you may need to put a throat pack as well. Okay. So usually it's not always required, but again, this will be a thing which you will be discussing with the surgeon. So actually, we will discuss the other surgery separately. So okay, so one topic which they can ask you a number of times is how will you handle a airway upper RTI in a pediatric patient? Okay, so in pre-op evaluation, if a patient has a upper a respiratory tract infection, so what should be your approach? Yes, Abdul Rahman.
Sir, it would depend if it is an active upper respiratory tract infection.
Mhm.
Like if patient has fever and cough, etc. running nose, then we would like to postpone because there is an increased risk of intra-op and post-op complications. Uh, but if the condition is in the case of adenotonsillectomy, and if the patient is has come for pre-op and has an active or just recently recovered from, then we would like to do a risk versus benefit situation, and we would like to proceed because it may be due to the condition causing recurrent infections.
Yes, you will just try to find a window, and then you will, so the actually the if it is yellowish colored sputum, so any fever, any respiratory findings, like there is wheeze, active wheeze, or there is a stridor or any things like that. Simple running nose is not the criteria to cancel a case. Pediatric burn, we will try to cover with the burn, mm, with the burn topic. In just, actually, this is update in anesthesia. Uh, I'm just trying to have a look. Anything specific? Any questions, please?
Sir, regarding the muscle dystrophy, what would be our special consideration?
Uh, Muscular dystrophy. Actually, it depends on the type of dystrophy. Usually, you will be avoiding suxamethonium, okay? Uh, because there is association of malignant hyperthermia, and there may be sensitivity to muscle relaxant. Like for example, in some conditions, if there is sensitivity to, so if you give muscle relaxant, it can have a very prolonged effect. Then if there is association with malignant hyperthermia, so that will be a problem. If muscular dystrophy, there is sometime if there are contractures, because it depends what sort of dystrophy it is. Sometime it is involving the cardiorespiratory system. Am I right? I don't remember the names, but they have association with cardiac. So
Yes,
you will be
Duchenne, I
evaluate.
think
Huh?
Duchenne muscular dystrophy has
Yes.
cardiac.
So you will be evaluating on that. Uh, that way. Actually, the separate topics are coming. So I will, because we will try to cover in those respective. Just let me see what is
Yes.
the
So
index here.
this time Viva was in Viva, there was a question of myotonic dystrophy.
Yes, it is one of the topic which I'm never able to prepare nicely. Myotonic dystrophy, and one topic is Duchenne. I hate these topics actually. Mm, Pediatric neuralgia, cerebral palsy. Yes, they can ask you about this question. Wilms tumor. Okay. So how will you manage this case? Wilms tumor. Yes, please. Pediatric patient will with Wilms tumor. What will be the anesthetic considerations? Who will tell?
So along
What is Wilms tumor? I think it is neuroendocrine tumor.
Nephrogenic embryonic tumor, sir, it is usually an early age presentation, maybe asymptomatic or could be having some abdominal pain,
Okay.
blood in urine, hypertension, fever, anorexia, and weight loss. And if the tumor progress, then other systems can be involved, like like other renal tumor which spread to liver and lungs. So the examination finding would be palpable or abdominal mass, which could be found on some ultrasound or some examination. And then we would do the other investigations like CT scan, like chest X-ray, renal function test, urine analysis, and the baselines would be done. And then the tumor pediatric specialist or oncologist, I think they should be taken on board about the tumor staging and uh, tumor grading. Most of the time, whenever the tumor, whether Wilms tumor or adult kidney tumor is found, nephrectomy is advised. Depends upon the condition whether the other kidney is good functioning or not.
Mhm.
Then the nephrectomy decision is taken, and the patient could be on the chemotherapy and radiation therapy as well. Our anesthesia concerns would be like any other abdominal mass with some with presentations for laparotomy.
Yes. Actually, like there are
And
certain
then we would,
concerns which are common for any cancer. So cancer concerns will be there. Chemotherapy and radiotherapy and anemia,
sir.
nutritional problems.
Yes, sir. We are more concerned with the remaining kidney function, if it is bilateral or not, if it is unilateral. I think most of the time it should be unilateral.
Yes, yes, it's
Uh,
majority time it's unilateral. So you said that if it is the other kidney is functioning or not, actually they have to remove the tumor, otherwise it will spread. Am I right? Is it
yes, sir. Yes.
so they have to remove it anyways. They maybe later on they can go put the patient on dialysis, or they may consider renal transplant if needed, but they have to remove it. They will not make it so complicated. Okay. So in our domain, because remember one thing, that pediatric anesthesia is a separate specialty. So and not everyone is expert in pediatric anesthesia. So they will not go to that much extent. So but this is a, because remember one thing, the number of time they create they take the question from these updates and articles. So I don't think so it is written commonly in books. So that's why there is real importance of you guys having a look on these articles. Nothing, there will be nothing special which will be written. Everything is written in the books as well, but you can extract topics, and the organization of these articles are amazing. Believe me, if you read from these things, you will never fail in the exam. I can bet on it. But you just have to understand how to construct your answer. Okay. So as they have written here some points: preoperative hypertension, preoperative anemia, hyperkalemia from tumor lysis, anesthesia drugs which can compromise renal function, prolonged abdominal surgery lasting 3 to 6 hours, large intra-abdominal mass requiring rapid sequence reduction, intraoperative hemodynamic instability, large fluid shifts and massive blood loss, intermittent inferior vena cava compression, intravascular tumor extension or embolization. Actually, the thing is that the basic concept will be the same, that there will be associated things. And then, if there is anything you need to optimize, if patient has received chemotherapy before, then the concerns related to chemotherapy will be there. And intraoperatively, it's like a laparotomy. So, and it's a, you can say, a surgery in which there is massive blood loss can occur, and abdominal, when they are doing the surgeries, would like a number of complications which can occur. So
The main concerns will be just like laparotomy.
yes, so it can occur laparoscopic. I'm not sure about it. I don't have experience of this as a laparoscopic surgery, but any surgery, in majority of surgeries, even nephrectomies, they are doing laparoscopic. So there are almost all the procedure which they are trying to do. I think it can be done laparoscopic as well. It depends on the size. Like this, it cannot be done laparoscopy, but maybe if according to the size they can consider. Okay,
Yes, sir. So
so you
then
see,
availability of blood, fluid
yes. And
management
And you
and
see,
monitoring.
read any topic. If you understand what we discussed yesterday, believe me, all the discussion, subsequent discussion is on the basis, the same thing which we discussed already. Okay. So,
Yes, sir.
yes, Zishan, you have just joined, I think, now. Okay. So, you can find everything arranged here. Let's see with just a second. I'm just looking at the pediatric questions which I made somehow. Just a second, please. Okay, so what are the difference in airway of pediatrics from that of adult, and how to deal with the problems arising due to it? We have covered about it. Anterior larynx, short trachea, and narrow part, big tongue, difficult nasal breather. So you will be using pre-oxygenation. You will try to have straight blade, anticipate difficult intubation, things like that. What are the difference in respiratory mechanics, buccal handle movement, and these one things? How does the neonatal and pediatric resuscitation differ from that of adult? We will discuss later. I did not touch intentionally this topic. We will discuss in detail. How does temperature compensation is different? We discussed yesterday. You see, now if you create the questions and then you will find the answer, it becomes much easier. Okay. Brown fat, we discussed yesterday, where are the sites, and how to prevent hypothermia in pediatric patient. We also discussed yesterday. How does renal function different in pediatric and neonate from adults? I think we have discussed a number of topics. Let me see if anything. Uh, Retinopathy of prematurity. Yes, actually, a funny thing. You know, do have you seen a case? Actually, once I did a case in which there was congenital problem in which the babies were insensitive to pain. They don't have any pain. So I don't know, any one of you have seen that condition or not. Another thing they can controversial things, cuff versus endotracheal tube. So, traditionally uncuffed tubes were used, but low pressure endotracheal tubes which are available, it's always better in my opinion. Again, but again, I say that it's a sort of controversial thing. You just because the better seal. So uh, I always prefer cuffed endotracheal tubes. Okay. Mm, so I think I will stop here. You can just have a look here because it's a long journey. Uh, don't be afraid from these topics separately. If you know the topics, you will just combine, you will take the pediatric concerns, and then you will just add on to the that disease. Pediatric burn, pediatric airway, pediatric any medical disease in pregnancy. Sorry, in pediatrics. So same principle will be there. Okay. So thank you very much. I will stop here. Inshallah, tomorrow, most probably, we will do what's in my mind is to do elderly. So some concerns with reference to elderly, and we will try to cover some of the conditions which they ask in elderly. Yes, Abdurrahman.
Sir, I have a question regarding foreign body aspiration and airway management in that
Okay.
regard.
I
I have
actually,
read
yes, yes,
what we
please.
what we usually do is, sir, we deepen the patient enough, and then we have a preset oxygenation mark at which we will take over from the surgeon. Is it
Mhm.
safe to explain it like that?
No, no.
Should
Actually,
we?
it's actually it's there in foreign body. There is no fixed answer. Okay, it depends on where is the site, what is the history, how much time has been gone. So there are so many factors about it. So there is not a single word answer. How much is the respiratory distress? What is the probable location? Okay, even because even if you are trying to touch the baby can cry, and even this cry can that it can cause pushing of the foreign body. So generally, it's always better to secure the airway. Okay, when you are trying to give it to the surgeon, why can't you put an endotracheal tube if possible, if it is located the pathology is allowing you. Okay, if or the surgeon can pass a rigid bronchoscope and you can attach the ventilation through it. Am I right?
Yes, sir.
So you can attach the ventilation, whether the baby is spontaneously breathing or you are giving some shallow breaths. So like you can do in that way. So foreign body, like and again, there is a variety in presentation of foreign body. So respiratory, your approach will be according to the respiratory distress, according to the history, according to possible foreign body, according to the location. So there are so many things. If it is creating obstructing, sometime even pushing in further deep is easy to relieve the obstruction, because if obstruction is there, patient will die. So maybe at some time it's better to even push it so that you have time to manage. Okay. So
Sir,
like
if
that.
the surgeon is using rigid bronchoscope and we are ventilating
Hmm.
with it, isn't there increased chance of aspiration?
How?
Because patients are maybe full stomach and
Yes, you are
which
right.
will be
But actually in that case, a number of time you try to maintain the spontaneous ventilation if permitted.
okay.
If you are ventilating, of course, it's a challenging thing. Okay. So I will try to cover this foreign body topic in airway, in ENT, inshallah. Okay. So, inshallah, tomorrow we will discuss elderly with all the possible. I will try to cover TURP, cataract, fracture hip. Um, even I will try to have a look what we can discuss about elderly. Okay. So thank you very much. Unfortunately, today I'm a little low in energy, so I'm not able to speak. That's why maybe I could have covered more, but actually the basics which we have covered, that if you know the pediatric physiology, pharmacology, and anatomy, and you know how to proceed anesthesia care in any pediatric patient, believe me, you will feel the difference. You will feel the difference because then if you will go to the individual topic, you will find only few specific things. You just chalk out the diseases, and you will find very specific small 2 3 things which are extra. Same concern in premature baby, same concern in neonate, same concern in pediatrics. IV line, anxiolysis, respiratory problem, cardiovascular problems, consent issues, immature kidney, immature liver, these are there in every patient. Use of EMLA, how will you induce the patient, how will you do the maintenance, how will you give the analgesia, how will you extubate the patient, what are the things in the post-operative care. The babies can like choke, the babies they have limited reserve of oxygen, so these things like that. Okay, so that's I think that's enough for today. Inshallah, tomorrow I will try to cover this elderly topic. Okay, bye bye. Assalamu alaikum.
सर बहुत बहुत शुक्रिया सर
Sir, thank you, sir. Allah Hafiz.
थैंक यू